جزاكم الله خير. بس اوكي. في مشكلة؟
أنا كويس؟
لا بدي اشوف. لا اتس اوكي فاين. Enjoy this new approach in decision making in keratoconus after lunch. Actually, it is a practical approach rather than the academic lectures. I'm not going to present each treatment option and indications, contraindications, what to do, side effects, so on. So I'm not going to do this because all of you know everything, but I'm going to reshape the knowledge in a better way to make it easier to take a decision. So it is a new practical approach, and we will go through giving a name to what we see on corneal topography, because we have to differentiate between keratoconus, pellucid marginal degeneration, keratoconus suspect, these terms, all of these terms, in addition to the characteristics of each entity of those ectatic corneal diseases. Then I'm going to show you a new categorization of management modalities. So same management modalities, but new categorization. And I'll show you then my functional approach. It is functional based on vision, rather than K reading, thickness, all of these stuff. Then I'll show you some examples. Now, 1 hour was allocated for this lecture, but we have sufficient time, more than 1 hour, 1 hour and a half. So it will be an interactive session. So please feel free to ask any question at any time, and we can go to other subjects like cross-linking, intracorneal rings, if you have specific questions about those. So starting with when how to give a name to what we see on the topography. Actually, ectatic corneal diseases can be grouped into 3 categories. The first one is established ectasia, or ectasia per se, and para-ectasia, and cornea with high potential to develop ectasia if we do corneal refractive surgery. The established ectasia includes keratoconus, pellucid marginal degeneration, pellucid-like keratoconus, keratoglobus, and post-laser vision correction ectasia. I'm going to talk about all of these in terms of topography. When you have topography in your hand, how to know that this is keratoconus or not, how this is pellucid marginal or not. So para-ectasia includes keratoconus suspect and frost keratoconus. These 2 entities are similar, but in terms of research, we have to differentiate between both. Cornea with high potential to develop ectasia if we do corneal refractive surgery includes posterior keratoconus, apparently normal cornea, and unclassified abnormal cornea. So starting with the first one, which is established ectasia, or ectasia per se. Whenever we see abnormal anterior curvature map, as you see, it is abnormal. We find that there is inferior steep with, let's say that it is not that large, skewed radial axis, but however, any abnormality on the anterior curvature map, which is accompanied with posterior elevation map abnormal. How do we know? We have to look at the elevation map, best fit sphere, displayed in best fit sphere, not best fit toric or ellipsoid, 8 millimeter diameter. This is the standard. We look at this symbol, which is the small circle here, which corresponds to the thinnest location. And we look at the number which is nearby it or on it. In this case, it is plus 31. Plus 31 is very high. So we have abnormal posterior curvature, abnormal posterior elevation map, and abnormal anterior curvature map. This is keratoconus, okay? Because we have abnormal anterior curvature and abnormal posterior elevation, regardless of thickness map. We don't depend on the thickness map. Why? As you see, this is keratoconus and the thickness map is very good and the cornea is thick. So that we can differentiate this from normal thin cornea. As you see, this is a thin cornea, 475 in the center, but we have anterior curvature map normal and posterior elevation map normal. So thickness map is not an indicator for keratoconus. This is pellucid marginal degeneration. Why? Because we have crab claw pattern on the anterior curvature map and abnormal posterior elevation map. But we have the bell shape on the thickness map. Why? Because pellucid is characterized by a band of thinning in the inferior cornea. So this is a hallmark of pellucid marginal degeneration. We have to see this pattern or any other similar pattern on the thickness map. This differentiates this entity from the pellucid-like keratoconus. This is pellucid marginal degeneration, very thin cornea in the inferior part, and this is bell shape as you see. Okay, now this is PLK. PLK means we have crab claw as well. We have abnormal posterior elevation, but we don't have the bell shape on the thickness map. This is why it is called pellucid-like keratoconus. So it is keratoconus, but because it has the crab claw, it is quite similar to pellucid marginal degeneration, but the only sign that differentiates both, the thickness map does not show the bell sign. Why I'm differentiating this? Because you know the behavior of each category or each entity is different. For example, pellucid marginal degeneration is a progressive disease. Whatever the age is, if the patient is 50 and he has pellucid marginal degeneration, we have to do cross-linking if other criteria are eligible for cross-linking. Why? Because it is a progressive disease. While if we see keratoconus or pellucid-like keratoconus at age of 50 or 40, then it is keratoconus, so most probably it is stable, and we don't do cross-linking unless there is progression. Okay? This is why we have to differentiate both. In addition, in pellucid marginal degeneration, we cannot implant a ring in this area because there will be perforation unless there is sufficient tissue to avoid this problem. Okay? In addition, because the problem is inferior, even if we implant a ring here, the effect of the ring may be unpredictable, except in some cases. In addition, if we want to do keratoplasty, because this is a very thin area, suturing at this area might be very difficult. So, as you see, if we know what we see, we know how to manage, and we predict the problems that may occur. So this is pellucid, and this is pellucid-like keratoconus, and this is keratoglobus. In keratoglobus, we find generalized steepening of the cornea and generalized thinning of the cornea extending to the limbus. Very, very generalized. So it is not only a pathology central or paracentral. Like in this case, look at the very thin cornea all over. Okay, now post-LASIK ectasia. This is a case of ectasia after LASIK. Ectasia may happen after PRK as well, and after SMILE as well. So, many factors behind this, of course. However, in a tomography point of view, it may take any of the previous shapes. Okay, so post-laser vision correction ectasia, it may take keratoconus shape, pellucid-like keratoconus shape, or even pellucid marginal degeneration shape. So, in ectasia, it might be any of the previous one. We come to the para-ectasia, keratoconus suspect and form frost keratoconus. What are they? Look at this. We find this abnormal anterior sagittal band. Why it's abnormal? Difference in K reading between this point and this point, more than 1.5. This is 43.4 and this is 47.6. So more than 4 diopters difference. Okay, so this is abnormal. Okay, but what about the posterior elevation map? It is plus 12, which is normal. So the posterior elevation is normal, but the anterior curvature is abnormal. So this is called para-ectasia. It is not ectasia. Now what's the difference between form frost keratoconus and keratoconus suspect? It is the same shape. Both are the same. Abnormal anterior curvature, normal posterior elevation. But if one eye has keratoconus, frank keratoconus, and the other eye has the previous pathology that I told you about, it is called form frost keratoconus. Okay? So here we will see abnormal anterior curvature, but normal posterior elevation. And in this eye, in the left eye, we see keratoconus. While in keratoconus suspect, the other eye might be normal, so no keratoconus in the other eye, or might be the same problem in both eyes. So this is called keratoconus suspect. Form frost keratoconus only if the other eye has keratoconus. Okay, this is called para-ectasia. So what is para-ectasia? It is abnormal anterior curvature, while the posterior elevation is normal, regardless of the thickness map. As you see, thickness map, just we look at it if we want to differentiate between pellucid-like keratoconus and pellucid marginal degeneration. But it is not a factor to say this is keratoconus, this is para-ectasia. It is not a factor in definition. So this is an example. This is form frost keratoconus. Left eye has keratoconus, as you see, abnormal posterior anterior curvature, as you see in the left eye, while the other eye, the right eye, has only abnormal anterior curvature. The posterior elevation is normal. So this is form frost. Now this is a case of keratoconus suspect. Both eyes, right and left, have the same abnormality, which is abnormal curvature, but the elevation is normal. Plus 4 here, plus 4 there. Now why it is abnormal? Because there is a difference in this eye. I think there is a difference of 2 diopters in the right eye. There is a difference of 2 diopters between the inferior and the superior. Second circle, we look at the second circle of numbers. This is the first circle, this is the second circle. So we look at this one and this one on the steep axis, and the difference, if it is more than 2, more than 1.5, so it is abnormal. So this is called keratoconus suspect. Cornea with high potential to develop ectasia if we do LASIK or PRK or SMILE. It includes posterior keratoconus, apparently normal cornea, and classified abnormal cornea. What is posterior keratoconus? It is just opposite to paraectasia. Abnormal elevation, posterior elevation, but the anterior curvature is normal. Okay? These are the cutoff points, of course. In myopic people, the cutoff point for the posterior elevation is 18, and in hyperopic people, the cutoff point is 28. So above these numbers, it is considered as abnormal posterior elevation. And if the anterior curvature is normal, we call this posterior keratoconus. Now, posterior keratoconus usually, in more than 90% of people, is congenital malformation. It is not a real ectasia, and usually bilateral in both eyes, and usually it is not progressive. So it is malformation rather than ectasia, bilateral, and not progressive. So whenever we find abnormal posterior elevation in both eyes, it might be malformation and corneal shape. But we have to monitor or observe any progression, okay? While if it is ectasia, usually we find it unilateral or maybe bilateral, but one eye is more than the other eye, so asymmetric, okay? And progressive. If we follow up, then it will be a frank keratoconus. If we touch this cornea, it will develop ectasia if we do LASIK or PRK. Now, apparently normal cornea, which is a very normal cornea, but brother, sister have keratoconus. So there is a high potential to develop ectasia in this person, although his cornea is very normal. Unclassified abnormal cornea, when this cornea has one high risk or two moderate risk factors of this table. Okay? This is a table which is scientifically based, and I'll show you the references that I took these numbers. So it depends on anterior KM, thinnest location, astigmatic study, anterior sagittal map, elevation maps, corneal thickness map, thickness profiles, relative thickness map, and inter-eye asymmetry. Well, if we have two moderate risk factors in one eye, it is of high potential. If we have one high risk, it is of high potential to develop ectasia if we touch the cornea. So as you see, this categorization will make it easy for you to know what you see and to know how to manage. Okay, these are the references. Okay. Now, characteristics of these entities. Yes. Normal anterior curvature. The posterior elevation. What about it? Normal. So one eye is normal, and the other eye. Very good question. I classify it as formed frost keratoconus. Formed frost keratoconus might be one eye normal, and the other eye is keratoconus. So you have to consider it as formed frost keratoconus, and it needs monitoring. It doesn't need cross-linking. No cross-linking. Even if it is, there is a problem in the anterior curvature map only, and the posterior elevation is normal, okay? The other eye is keratoconus. This is not a reason to do cross-linking for this eye, which is either it is normal or just anterior curvature. Okay, just monitor. Okay. Fine. Characteristics of entities. Let us now predict from the topography that I'm going to show you. What is the vision of the patient? Okay, you can, from the topography, predict how the patient sees, the quality of vision and the quantity of vision, even without examining the patient. For example, this is a case of keratoconus. Okay, we have plus 38. As you remember, if the patient is myopic, the cutoff value is 18. If he is hyperopic, it is 28. So in both cases, It's very high. Here, as you see, it is skewed, there is no skewed radial axis, but this is asymmetric porti because we have this point is larger than this point, more than 1.5. Okay, so this is keratoconus. Now, how do you imagine this patient? Is it a mild keratoconus, moderate stage keratoconus, or advanced stage of keratoconus?
Mild.
This is mild. Exactly. Why? Still, Km is 45, Kmax is 50, as you see, not high elevations that much. Thickness, 448. So it is mild keratoconus. Okay. Now, is the irregularity central, paracentral, or peripheral? Paracentral. Very good. Okay. If it is paracentral, does it affect night vision, day vision, or both? Actually, this depends on pupil diameter, right? If the pupil diameter, for example, 3 millimeter, it will not affect this. You can imagine this only area, the patient will suffer from the astigmatism, which is almost 2.5. If it is larger than 3, okay, 5 millimeter, for example, then yes, it will affect both. Now, what do you think the patient is suffering from regarding high order aberrations? Do you think he is suffering from spherical aberration, coma, or trefoil? Coma. Coma means in the center of the cornea, the refraction is not equal. It is asymmetric, either in the horizontal or in the vertical. This is coma. Okay? Trefoil is a peripheral irregularity in the cornea, peripheral. Spherical aberration means that the cornea is symmetric and regular, but maybe it is steeper in the center than the periphery, or vice versa. Okay? So in this case, we have irregularity. So for sure, it is not spherical aberration. It is central or paracentral, so it is coma. Okay? Now, coma will affect, of course, the quality of vision, causing coma-like shadows. So the patient is suffering from ghost images, shadows to the letters that he reads. Okay? But not that much severe because it is mild keratoconus. Great? Okay. So it is mild. Now we come to this one. What do you think? This is grabbed low. We have plus 19, almost plus 19, so it is borderline. Let us assume that the patient is myopic, so it is keratoconus. If the patient is hyperopic, it is not, because the cutoff point is 28. So let us assume that this is a keratoconus case. As you see, thickness is very good. Okay? Now, do you think this patient is suffering from irregularities more than the previous one or less?
More than.
Astigmatism is 1. It was 2.5. Okay? Again, it depends on pupil. Okay? The size of the pupil. But however, you feel that this irregularity is more towards the periphery. Okay. But still mild. We come to this one. Kmax is 56. Okay? Very high posterior elevation. Now, although it is moderate keratoconus, but do you think this patient is suffering from quality of vision, quality, more than the first picture or less? Why? Exactly, because it is peripheral. If you put your hand here, then as you see, the center of the cornea is still irregular, but let's say is more regular than the one that we saw, the first one. Okay. This one is very severe, advanced keratoconus, as you see. So this patient is suffering, no, it's mild. We can consider it as moderate as well. I think because, K readings are still 54, and the amount of astigmatism 2.8, and it is peripheral, as you see. Now, this is severe or advanced. No, it is moderate as well. Okay. 56. Still. Okay. Now, which patient is suffering of quality of vision? This eye or this eye? This one or
this one.
quality of vision, not quantity. Because this one is central. Okay? So this patient will suffer from spherical component, more spherical component. Maybe if we do the refraction for him, we can find that he has maybe -5, -6 sphere, and astigmatism is here, 34, 51. So the gradient of difference is about 19, or less, 17, almost 17 diopters gradient of difference, as you see. So this patient is suffering from coma more than this one. He's suffering from coma more than this one. Because coma happens because of the difference of gradient power between upper and lower, or between temporal and nasal. I don't want to say, because I'm afraid it's moderate and then advanced. Okay, advanced. Okay. A larger part of the cornea is affected. Now this patient is suffering from spherical component. Huh? As you see, astigmatism is very minor. Okay. We talked about this. Okay. Now, when we classify, yes.
Do you classify mild, moderate, advanced according to the quality of vision or according to any parameters that you've shown?
No, this is the aim of this lecture. I classify based on vision. So this is what I call functional classification, rather than the K readings, because there are many classifications depending on many parameters. For example, the Kromish-Amsler, after that Alio Shabaik, after that Ishii, and there is another one which is the Retics. All of these depend on many parameters, but if you want to follow these, you will find many cases that are graded as grade 1 because the K reading is like this, grade 2 because the thickness is like this, and grade 3 because, for example, the high order operations is like this. So which one is the one that you are going to grade it? Is it grade 1 or 2 or 3? So there will be a lot of conflicts. So I found that the functional classification that I'm going to show is the best one. And really it helps me personally, as I will show you later, how to choose the best option. Now, how to know whether this case is progressive or not? We want to document progression. First, age, of course. Now, some countries may consider age of 20 is the cutoff. If the patient is below 20, they cross-link immediately without waiting. Above 20, we have to observe. Some countries, no, 25 is the cutoff. Some countries, 30 is the cutoff. So if the patient is 28, we go immediately to cross-linking in some countries. Actually, all are correct because this is based on the culture, the genes, the environments. Like in Gulf area, it is very aggressive. It will progress even after 25. It depends then. However, we don't need to document progression when the age is below the cutoff value, cutoff age. When the case is PMD, or arterial marginal degeneration, all are considered as progressive. By the way, arterial marginal degeneration is one of the indications for cross-linking. Although it is not we don't know it as an ectatic corneal disease, but it is. Okay, and it is very similar to pellucid marginal degeneration. Post-LASIK ectasia, if you find a patient who had LASIK and then is developing ectasia, don't wait. You don't need to document progression. Immediately you can go for cross-linking if other parameters are good. So as you see, no need for documentation for these three. But otherwise, we need to document progression. Now, what's the meaning of progression? Progression is getting worse, but we need to follow parameters. We need to follow criteria in order to say that this is progressive and we are going to do cross-linking, for example. There are two ways to document progression. Either to go for Bellin ABCD Categorizing staging if you have Pentacam and you have the software of the Pentacam. Okay. By the way, I'm going to have to give a lecture about 30 minutes in the Pentacam booth. I have no financial interest. I did not receive any support from any company. Just for people who are interested in Pentacam, I'll give this after the lecture on the booth of the Pentacam about a few tips there, if you like to know. However, I'm going to explain everything here as well. So, Bellin ABCD Categorizing staging, or if you don't have it, you have to follow these two criteria. For example, if you want to document progression for a patient, you take 3 captures now, and very good captures. And you see the KM of the anterior corneal surface. Which one is in the middle? For example, 47, 47.2, 47.4. I will take the capture which has 47.2. I will depend on this one. Next visit, which might be 1 month, 3 months, 6 months. However, the time that you would like, of course, it should be shorter follow-up for children and women, and it can be longer for male. So the next visit, I'm going to do 3 captures as well, and I look for the one with average KM in the middle one, and I will depend on this one. Then I compare this one with that one. I'm talking about KM, okay, as a leader. Then I look at the Kmax, maximum K, in the first one, and maximum K in the second one. If there is a change more than 2 diopters, more than 2, not 1, you will find huge number of studies mentioning that 1 diopter of Kmax change is an indication to go for cross-linking. This is over, okay? This is over-treating people. We have to find 2 diopters because there is a noise of the machine. What does the noise mean? What does it mean? Mean that there is a standard deviation for each parameter, for each eye, in same session, for the same device, for the same technician who is taking the capture. For example, if you take the capture 1, 2, 3, you compare, you may find plus minus 12 microns in thickness. Okay, in the same session, first for the same eye. Why of this? Because of tears, because of the biomechanics of the cornea, lids, squeezing, technician errors, patient errors. However, 12 microns plus minus in normal population. And it might be more than this when the cornea is very distorted. The same applies for Kmax. So the noise of the machines is about 2 diopters. So the change should be more than 2 diopters, and the big and. thinning at the thinnest location more than 15 microns, together we say there is progression. But if we find one and the other one did not change, no progression, it is an artifact. Okay? Surface eye diseases affect very much taking any capture. So if you don't have this, you can go for this. But what is this? This one, as you see, gives a staging 0, 1, 2, 3, 4, based on 1, 2, 3, 4 parameters. The first one from the anterior surface, the second one from the posterior surface, the third one thickness, and the fourth one is vision. Distance corrected visual acuity. You input the vision of the patient, then it displays which one. As you see, this is keratoconus. For example, if you have a patient like this, and then like this, sure, it is progression. Okay. Of course, I disagree with the, personally, I disagree with the visual acuity to depend on if we want to classify keratoconus. Why? Because visual acuity is very much fluctuating in people with keratoconus and depends on the optometrist and depends on the condition that we are measuring, the refraction. Depends on patient is tired or not tired. So, because it is the corrected visual acuity, and in addition, there are special techniques to measure refraction in people with keratoconus. Special techniques. It's not a refraction, normal refraction. We have to depend on the split. We have to do special tricks in order to give the best refraction. So, but we have to put it in order to give the classification. Okay. Number 3, categorization of management modalities. Okay, now as you see, the queen of treatments is the glasses. This is the queen. Okay? We are surgeons, and we don't think about this, and we don't think about the prime minister, which is the contact lenses. We think about soldiers, always, because we are fighters. Okay? This is wrong. We have to be very conservative. Wherever the queen work, let it work. Let her work. Prime Minister work, okay, let him work. And don't go to soldiers. Okay? Let's now discuss the indications, contraindications for each one. Just in general. Of course, we are not going in details, because all of you know the details. So when I will use, when do you think that I'm going to use glasses?
Well, the patient
Well,
is
vision is good.
happy with,
Very good. When the patient is not suffering from the halos, glare, shadows, or maybe suffering a little bit, and his vision, the corrected distance visual acuity is good, and the amount of refraction is small or moderate, not very thick glasses like this.
The astigmatism is not so deep.
Very good. That's it. Contact lenses. When can we go for contact lenses in patients with keratoconus?
When patient can wear.
Exactly. So any patient who is tolerant to contact lenses, even if their vision is good or not good, because contact lenses will regularize the anterior refracting surface. Okay? It will not regularize the cornea, but I mean it will create a regular anterior refracting surface, so it will compensate for the irregularities of the cornea. So if the patient can wear contact lenses, let him wear contact lenses. Now, don't mix between, okay, and if the case is progressive. I'm talking about rehabilitation of vision. Okay? But if glasses can work, then let glasses work. Better than contact lenses. Okay? Because you know, contact lenses, side effects, and about fitting the contact lenses practically.
Better vision.
Yes, but if it is like early keratoconus or mild keratoconus, many patients are happy with their glasses. Yeah.
So the rest are more expensive.
Yes, exactly. Now, what about cross-linking? When do we do cross-linking? When the case is progressive, either because of the age or pellucid marginal degeneration or corneal marginal degeneration, or the criteria, or yes. Okay, now we can augment some treatments with cross-linking, like if we do PRK, if we do LASIK. Is that true? No, very good. Very good. This is the point. I don't believe, and I'm against, and I will fight forever against LASIK extra and PRK extra, LASIK plus and PRK plus. I fight against it because it is not scientific at all. It is money-wise. It is money-wise. Why? Now, LASIK extra, PRK extra are not done for keratoconus. If it is keratoconus, okay. Now we are going to talk about this issue. But if the patient is coming with a cornea which is borderline, it is not keratoconus. For example, keratoconus suspect or formed first keratoconus, okay? Why to do PRK or LASIK to this patient? Why? Why to say that, no problem, we can augment by cross-linking? It is not scientific. If the cornea is thin, but very normal, for example, 450 microns, and the patient has, for example, -2. -2 can be corrected by ablating 30 microns, 30. So the cornea, after the operation, will be 420. So some doctors may say, okay, 420, so it's better than, it will stay more than 400 microns. So why not to do LASIK or PRK and augment it by cross-linking? This is what I'm talking about. This is wrong. Why? Because when you read the articles published about LASIK extra or PRK extra, what is the concern of the hypothesis? The hypothesis say that if we want to avoid ectasia, then we have to do cross-linking in these borderline or gray zone corneas. Okay? I can say that none of the papers published have any clue or have any evidence that the incidence of ectasia was reduced by this operation. Because statistically, if we want to say that this method is okay, the hypothesis is preventing ectasia. So we have to have two groups. One is control group and one is study group. The control group should have the same gray zone corneas, and we do LASIK or PRK on those corneas. The other, which is the study group, should have the same irregularities or same gray zone, and we do LASIK extra, PRK extra. We should follow up both groups at least 5 years to 10 years, and then we see the incidence of ectasia in both groups. And if we find that in the study group, the ectasia is nothing or less, significantly less than the other group, then we can say LASIK extra, PRK extra are okay. But you will find none of the studies published mention ectasia in their outcomes. They just say effective and efficient in terms of visual acuity, which is not the hypothesis. Okay? In addition, if we want to carry such a study, we should have at least 100,000 patients, because whenever the incidence of something is very rare, there must be a huge number of people to be studied in order to get a scientific significance. In addition, this is not an ethical study because we are doing LASIK or PRK on corneas with high potential just to make them as a control study, which is not ethical. So this study is impossible. So no way to go for LASIK extra or PRK extra unless we want money. Now, if we want to go for topography and topography guided treatment or wavefront guided treatment to augment that with cross-linking. Okay? In keratoconus, here I can say yes, because scientifically there are a lot of studies. There is a lot of studies. Athens protocol, wavefront guided treatment, PTK, or what is called PTK with cross-linking. There is a special return protocol. Yes, exactly. So there are protocols for such. We do this just to treat irregular astigmatism, not the sphere. If the patient has -5, -2 cylinder, we will treat -2 cylinder, not the -5, because we don't want to lose tissue. The cornea has small amount of tissue because it is keratoconic. We don't want to lose much tissue. So usually we ablate about 50 microns of the stroma and we do the cross-linking. Now there is a controversy whether to go for PRK and cross-linking in the same session, or PRK now, cross-linking after 6 months, or cross-linking now, PRK after 6 months. Okay, controversy. No, I'm not going to go through this. But in all cases, even in astigmatism, we don't treat the full amount of astigmatism. For example, I said we ablate 50 microns. If the patient has -2 cylinder, we will ablate about 40 microns, because in customized laser vision correction, we ablate more than usual. Because the -2 will ablate only 40 microns, am I allowed to correct the full 2 diopters of the astigmatism? No. Why? Because the 2 diopters that the patient is suffering from is composed of 2 components: the real astigmatism and the coma effect. The coma will be translated by refraction into astigmatism as well. So the -2 cylinder is not the real cylinder that the patient has. It might be -1.25 plus -0.75 because of the coma. So we should not over-treat the patient. We have to take almost 70% of the astigmatism to treat him or her. We come to the rings. Now, if we want to do the rings, do you think that we can go for rings in mild cases, moderate cases, or advanced cases? In advanced? No. Okay. So moderate cases. Correct. Here, in mild cases, in cross-linking with topography guided or customized laser vision correction, mild. Here, in moderate. Now, the full ring, regardless whether it is myoring or there are new designs of rings now, full ring. The full ring, okay, the 360 degrees ring, we usually do it in advanced cases. Whenever there is Vogt's trial.
High myopia?
Yeah, it is myoring, means ring for myopia. You are right. But later on, it was used for keratoconus management as well. And it reduces the K readings almost by 10 diopters. So we usually use it when the K readings are above 55. And usually we augment it immediately with cross-linking because it is advanced keratoconus and the cornea is very floppy. So we have to augment it with cross-linking. Phakic IOLs. When do you think phakic IOLs can be implanted in keratoconus? When do you think?
Good vision.
Good vision?
High myopia.
High refraction?
Stable.
Stable. Very good. especially if we want to go for toric lenses, okay? Because if it is very irregular astigmatism, we cannot implant toric lenses, okay? Because toric lenses have the same refraction along the axis of it. If we want to put it in an irregular cornea, behind an irregular cornea, we may sophisticate the problem. We may create a new astigmatism with the new high-order aberrations that the brain has not get used to it. Okay? Keratoplasty, whenever there is no other place. Now there is a promising technique, which is the CK, conductive keratoplasty. It is an old technique, but now it is being developed, and it may get this position before keratoplasty. I'm going to publish, inshallah, in Journal of Cataract and Refractive Surgery, an article with a doctor from USA and a doctor from Ireland about the conductive keratoplasty. Very soon it will be published. However, treatment parameters. As you see, we have many parameters that we should not depend on. Okay, previously we depend on, but actually they sophisticate the problem. Transparency, voct striae, progression, age, gender, thickness, Kmax, refraction, astigmatism, visual acuity, potential visual acuity, and high-order aberrations. So many. So if I want to depend on this, I'll make maybe plenty of tables to say whether if you have this one, that one, this one, that one, then go for this. If you have that one, this one. So actually, just I'd like to show you this, just to show you that they have an effect on the outcome of the treatment, but they will have less effect on your decision if you follow the functional decision tree that I'm going to show you. Of course, transparency will affect your decision as well. If the cornea is not transparent and has a scar, what to do? Can I implant a ring? Can I go for cross-linking or do topography, a guided treatment? Of course not. Voct striae, it means that very advanced keratoconus. So usually you don't go for intracorneal rings. Not necessarily, but yes, most probably. Progression, if it is progressive, then we have to consider cross-linking. Age, as I said before, gender, thickness. If the cornea is 300 microns, we cannot go for cross-linking. We cannot go for intracorneal rings. We cannot go for, we may go for ICL. Kmax, if it is 70 or 75, the intracorneal rings will not affect. Refraction, if the patient has -1, -2 sphere, -1 sphere, -2 cylinder, can we go for phakic IOL? No, we don't go. Astigmatism, if the patient has -1 cylinder, do we go for intracorneal rings? No. Visual acuity, if the incorrect visual acuity is 0.3 and the best correct visual acuity is 0.4. So very low visual acuity. We have to measure potential visual acuity. If it is still poor, then what to do? Rings will not affect, phakic IOLs will not affect, topography guided will not affect. So most probably you have to go for keratoplasty. High order aberrations. If the patient is suffering from minor high order aberrations, we go for glasses. If he is suffering from higher, then we go for other treatments. So these, just to give you an idea how to think, but they will not lead you 100%. Okay, so I classify or categorize treatment options into 3 categories: aiding measures, corneal remodeling, and corneal transplantation. corneal transplantation, we have the LKP, PKP. Corneal remodeling, laser, which is the customized laser vision correction, or intracorneal rings. They remodel the cornea. They change the cornea, the shape of the cornea. Aiding measures, contact lenses, glasses, or phakic IOLs. Right? Okay. How to use them? This is the functional approach. First of all, if, let's say that vision is either good or poor. We don't have fair vision. Fair vision, which is in the middle. No. Either good or not good. Good when the corrected visual acuity is more than 0.6. When the difference between corrected and uncorrected visual acuity is more than 2 lines, and when there is insignificant high-order aberrations. This is a good vision. Otherwise, it is a poor vision. Okay? If the vision is good, we can go directly to aiding measures, either contact lenses or glasses or phakic IOLs if the refraction is high. Or to make the shape of the cornea better, to reduce the amount of astigmatism, to regularize the cornea, we may go first to corneal remodeling. So we may go for laser vision correction, customized laser vision correction, or intracorneal rings. After that, I can go to aiding measures. So either this one or that one. Now, if the vision is poor, still I have hope. I don't go immediately to transplantation. Either the vision is poor, but the potential visual acuity is good, or vision is poor, but the potential visual acuity is poor as well. So when vision is poor and potential visual acuity, what's the meaning of potential visual acuity? It is the visual acuity with hard contact lenses. Potential visual acuity, I always, when the vision is less, the corrected vision is less than 0.6, I send my patient to an optometrist to fit a hard contact lens and measure vision with the contact lens, to know whether he has poor potential visual acuity or good, because it will affect the decision. So, if the visual acuity is poor, for example, corrected visual acuity is 0.3, and it remained less than 0.6 after putting the contact lens, then it's very, very poor vision and no way to do any corrective or remodeling or something. I go for transplantation. But if, for example, 0.3 and with the hard contact lens it became 0.8, so the potential visual acuity is very good. In this case, either the patient can use contact lens, or we go for corneal remodeling. I can go for intracorneal rings or customized laser vision correction. Now, if we go to corneal transplant, because vision is poor, potential visual acuity is poor, after corneal transplantation, again, good potential visual acuity or good vision, let's say. If the vision is good, we can go to aiding measures. If we do transplantation to the patient, and maybe he will need, after the operation, transplantation, he may need contact lenses or glasses. And sometimes we may implant phakic IOLs if there is a very high refractive error after corneal transplantation. So this depends on his vision after the operation, either this one or this one. Of course, usually we don't do laser over the graft. We don't do intracorneal ring in the graft. We don't do this usually. Okay, so let me show you this. Again, if the patient has good vision I can go for contact lens, glasses, or phakic IOLs depending on amount of refraction and depending on his complaint. If he is complaining of high order aberrations, we can go for contact lenses. Okay, now if vision is poor and potential visual acuity is poor, we go for corneal transplant. After that, he may go for contact lenses, glasses, or phakic IOLs. If the vision is poor, but potential visual acuity is good, then we go for corneal remodeling, laser, or intracorneal rings. After that, he may go for aiding measures like contact lenses, glasses, or phakic IOLs. I'll give you some examples. Case number 1. This is a case of a patient having keratoconus. Let's say Kmax is it doesn't show Kmax here, but almost here, let's say about 47. So it is a mild case. Let's say it's a mild case. Now, this is the vision of the patient. Okay? This is the left eye. His old glasses is minus 1.5, minus 125. And the best correct visual acuity is 0.6. Now, I did a new refraction for him, and I could reach 0.8 by minus 2 sphere, minus 2 cylinder. So as you see, and potential visual acuity was 10, 10 over 10. So this patient has good visual acuity, as you see. Okay, so since it is good visual acuity, we go to the right wing. Either contact lenses, glasses, phakic IOLs, or remodeling, then aiding measures. Okay, very good.
Without
Now, sorry?
Without UBX, without crossing?
We will come to that now. Okay. So I fill a table to see the parameters. Now, this patient is intolerant to contact lenses. This patient is intolerant to contact lenses. And his thickness is 492. His refraction spherical equivalent is minus 3. Corrected visual acuity is 0.8. The patient difference between the not incorrect and best correct is 3 lines, which is more than 2. Potential visual acuity is very good. Kmax is 47. So, because he is intolerant to contact lenses, I'm going to remove contact lens from the options. Now, thickness is 492. So, all options are okay for him. Since the refraction is minus 3, so I'm not going to think about phakic IOLs. I'll remove it. Because his vision is very good, no need to go for laser and no need to go for intracorneal rings, especially that the Kmax is 47, which is very mild keratoconus. So especially the intracorneal rings, we don't need it with such very mild case. So in this case, either to go for laser vision correction, which is customized laser vision correction, or to go for glasses. I did tomography guided treatment for him. Now, this is pre-op, this is post-op, and this is the difference map. I could remove about 1.3 diopters of astigmatism and regularize the cornea. Case number 2. This is a case of keratoconus. It is more advanced than the previous one. Yeah, moderate. Now this patient, refraction, the new refraction, minus 5, minus 2.5 at 120. Now the incorrect is 0.05, best correct is 0.4. But the potential visual acuity is very good. So he has poor vision, but good potential visual acuity. So we are going to the left wing. poor vision with good potential visual acuity. Let's fill the table. This patient, unfortunately, he is intolerant to contact lenses. Thickness is 424. Refraction is minus 6.25. Vision is 0.4. Difference is 4 lines. Potential visual acuity is 0.8. And Kmax is 56. So what do you think? What should we remove?
Age of patient.
Let's say he is 35. So no need for prosthetic. Okay. What should, okay, now we have to remove contact lens, okay? Fine.
Customize laser.
Okay. Thickness. What about thickness?
Customize laser.
Yeah, thickness. But thickness is not sufficient to go for.
At 5 degrees.
First of all, minus 6.25, very high spherical equivalent.
Yes.
And the astigmatism was, I think, how many? 3. The astigmatism 3 or 2. 2.5. Okay. If I want to treat 70% of the 2.5, it will be how much? I think 1.75 multiplied by 20 microns. It will be almost 35 microns. Okay. And in topography guided treatment, we should not go below 400 microns. While here we have only 24. Right? So he is not eligible for topography guided treatment. Okay, so let's one by one. Contact lens, okay, removed. Thickness is not sufficient for customized laser vision correction. Now, refraction. Glasses are not good for such refraction. Thick. Okay. Why? There is another cause why glasses are not good. Why? Because corrected visual acuity is 0.4. The potential visual acuity is good, but corrected visual acuity is 0.4. So glasses are not good as well. So, in addition, phakic IOL are not good because they do not give the potential visual acuity. They will give the corrected visual acuity. So, phakic IOL will be removed. So, intracorneal ring may be the best option, especially that Kmax is a bit high.
Maybe we can use
after intracorneal rings. Yes. If there is high, still high refraction and the corrected visual acuity is reasonable. Yes. So I implanted for him rings. This is pre-op. This is post-op. This is the reference map. So the patient had good result with the rings. This is pre-op, this is post-op, this is another visit post-op. So this is the difference. So regular cornea, almost regular cornea. Case number 3. Okay, we have this patient. Seems that this is keratoconus suspect because the posterior elevation is normal. We have abnormal anterior curvature, so this is either film frost keratoconus or keratoconus suspect. Let's see, because I forget it. Now, he has -1 sphere, -0.5 at axis of 70. Uncorrect is 0.8, best correct is 1. Potential visual acuity, of course, is 1. Aha, this is the left eye. This is the right eye. This is the left eye. Okay, so maybe I'm going to talk about this eye, the left eye, which has -7 sphere, -3 cylinder, axis 125, uncorrect is 0.05, best correct is 0.8, and the potential visual acuity is 1. Now what to do for this eye?
Zero.
Let's see.
Take it away.
Fake eye for -1. This is right eye. So glasses. Keep him on glasses. Okay. He is tolerant to contact lenses as well. Thickness, very thin cornea, but we have to monitor progression unless the patient is young. So laser cannot be done because very thin cornea, of course. Refraction is -125, so I'm going to remove intracorneal rings and phakic IOLs, as you see. Vision is very good, so we can go for glasses. K-max is good. So this patient, because he has progression, we can go for cross-linking followed by contact lens or cross-linking followed by glasses. The right eye. Now what about the left eye? -7, -3. Good vision with good potential visual acuity. So this is the right wing. Okay. He is tolerant to contact lenses, but of course we are going to do cross-linking before it. Okay. Thickness is 373. Wow. Cross-linking is not good for him. Okay, let's see. We cannot go for laser, of course. Even ring, we cannot go for it. I forgot to remove it. Refraction is very high. No glasses, yes, very good. Now, yes, K-max is 47.5. So either to go for cross-linking hypotonic followed by contact lenses, or cross-linking hypotonic followed by phakic IOL, or to go for myoring. Myoring will act in such advanced cases. Myoring full ring, full ring will act better than intracorneal ring segments in such cases with cross-linking, of course. So in the right eye, we can go for cross-linking followed by contact lenses or glasses. In the left eye, cross-linking hypotonic protocol, which I'm going to talk about now, followed by contact lenses or phakic IOLs, or with myoring during the operation. Now, what is the hypotonic protocol? You know hypotonic riboflavin. There is hypotonic riboflavin. If we want to go for hypotonic protocol, it does not mean that we have to use the hypotonic riboflavin the whole surgery. No. We go, as usual, for example, 30 minutes of riboflavin, then you go for 5 minutes of hypotonic. Every 1 minute, you put a drop. Every 1 minute, you put a drop for 5 minutes. Then you measure the thickness of the cornea. If the thickness is 400, you go for UV. If it is still below 400, you give additional 5 minutes of the hypotonic. So the hypotonic is not from the beginning. After the riboflavin, we put the hypotonic. Why not from the beginning? Because the hypotonic swells the cornea. And if we swell the cornea, we are going to cross-link a false tissue, a hydrated tissue. So the effect will be very less and maybe transient, and maybe we will not have an effect. So we want to gain only 50 microns to 70 microns more in order to be able to apply the UV safely. So we don't go for the hypotonic from the beginning. Okay, this is the hypotonic protocol. One more thing, try from now on to avoid using the riboflavin during UV application. Just put PSS every 2 minutes during UV application, whatever the protocol you are going to use. Why? Because the riboflavin blocks part of the UV ray, and it will give less effect. So we don't need the riboflavin during the UV. We need it before in order to saturate the cornea and to be a trace in the anterior chamber. but we don't need it anymore during the UV. So no need to keep using the riboflavin, which will block some or part of the UV, and at the same time, it will go on shrinking the cornea because the isotonic riboflavin shrinks the cornea because of the dextran it has. Okay? So it keeps dehydrating the cornea. We don't need it during UV application. I was asked about the best epi-on technique for riboflavin. The only proved technique is as follows. You have to use osmolar riboflavin, regardless of the trade name or the brand name. I'm talking about the composition. It should be osmotic cross-linking. Osmotic riboflavin. We put every 3 minutes 1 drop on the epithelium. Every 3 minutes. After 30 minutes, we check the anterior chamber. If we can see a green hue within the anterior chamber, then we can go to the cross-linking. If we cannot see it, we have to go on again and again and again until we see the hue, green hue in the anterior chamber. This may take 4 hours. 4 hours of application of the osmotic riboflavin, depending on many factors. Now, after I found the hue in the anterior chamber, I wash the riboflavin from the surface of the cornea completely. And I wait 5 minutes doing nothing, just PSS. Why? Because I want the riboflavin to clear out of the epithelium. Otherwise, it will make a shield within the epithelium and it will block the UV from penetrating through the stroma. So I wash the riboflavin, I wait for 5 minutes doing nothing, then I apply the UV. This is the best way of epi-on technique. Other epi-on techniques are still not proven. That's it. So if you have any questions, yes.
This case last is,
Yes.
I think about age.
Yes.
Very important. If age more than 40.
Yes.
Same procedure will go.
We don't go for cross-linking, of course.
And for ICL.
Contact lenses or glasses, the right eye, left eye, contact lenses, or phakic IOL,
Why fake?
because his vision is good. And, sorry, you said age?
More than 40.
Sorry. More than 40, no, I don't go for phakic IOL. Yes, I don't go. Of course, no clear lens extraction. For me, I don't do clear lens extraction if the patient has minus. I do it only when the patient is above 45 and has more than +4. Sorry? Yeah, toric IOL. It means that clear lens extraction with toric IOL. Yeah, I don't do it. Why? Because in the exam, in the Royal College of Ophthalmologists, okay, if you say that, you will fail.
Yeah, it is good.
Really, but I have this experience. I didn't fail, alhamdulillah, because I didn't say that. Clear lens extraction is indicated only.
It is more than 50, maybe not.
Yeah. I agree with you that it might help, okay, but it is not indicated scientifically or let's say agreement. General consensus, okay, general consensus. When there is more than, when the patient is above 45-year-old and has more than +4, plus, minus, no, nobody will agree with this. Maybe because of the risk of retinal detachment in myopic people. So there is no general consensus. I don't do it. If the patient is 40 or 43 or 45 and he has -6, I don't do it.
It's not first
No.
option.
For me, it is not an option. For me, it's not an option. If there is no cataract, I don't do it. Okay?
Yeah,
I may go for myoring.
Myoring.
We should to examine the lens. To also put here to see
Yeah, of course. Actually, if we want to go for cataract evaluation, there is a machine which called I think, OSI, which gives like an index to the density of the lens. And yeah, it may indicate doing so if there is like nuclear cataract, if you have early cortical cataract. Yeah. However, it is a cataract. But if it is very clear, I don't do it. Yes.
In a patient with a sensification between 450 to 80 and normal other parameter. What can we do to protect safety?
Okay, the question is if the patient has 450,
Not for 280 years.
yeah, between 450 and 480 microns, and very regular cornea, and he has small refractive error.
3, 4, 2,
Yeah. Below 470, I don't do PRK. I don't do LASIK below 500. I don't do SMILE below 470. I don't do PRK below 470. Yes. Some doctors may go for that up to 450. Some doctors. Okay? And many patients are happy without any complications. But personally, no, I don't do this. Yeah. I don't say that it is malpractice because there is also no general, no global consensus about this. What is the cutoff value? Is it 470, 460, 450? But for me, 470 is the lowest that I can do. Hypertonic protocol is epi off. Yes. Yeah, it will give you additional 50 to 70 markers. Additional, yes. Without the epithelium, without the epithelium, it may add to the stroma 50 to 70. Yes. Okay, what is the lowest age to go for laser vision correction? With cross-linking. You mean keratoconus? Ah, okay. Good question. Personally, I don't do it before age of 18, 18. Yeah, personally. I don't know. Other colleagues may go for 16 because, however, we are going to cross-link the cornea. Yeah, maybe, I don't know. But personally, below 18, I don't do topography guided with cross-linking. Yes, but cross-linking I do, even in children.
How much minimum age for the children? You have done?
My personally, 4 years under topical anesthesia, was very cooperative, 2 patients. Yes.
Sedation or something like that?
Sorry?
Sedation.
No, I didn't use that because they were very cooperative. Yes. Any other questions, comments? Yes.
Have your indications or criteria for the cross-linking has changed after this bit of customized cross-linking? Or there are certain papers saying cross-linking for myopes? Have your indications, are you so strict saying that
Yes.
if it is progressing your criteria,
Yes.
then only you go for cross-linking? Or
Yes.
or
No, I don't do refractive cross-linking. Refractive cross-linking for myopia, for example, in order to reduce the amount of myopia or reduce the amount of astigmatism, because there is unpredictable flattening effect of the cross-linking, in addition to sometimes haze, scarring. So why to expose the cornea for this?
you strictly follow the criteria of progression,
Yes.
even with the customized
What do you mean by the customized? The customized profile or what? The same indications for the customized profile.
Great experience regarding this hypertonic protocol. Because this young patient who had previous tracking of 414.
414?
424. Okay, so we took him for cross-linking, and after the epithelial removal, it was only 374.
It was
After
300.
epithelial removal, it was only 374 back.
300 what?
74.
74, okay.
Yes. So we thought we go for this hypertonic protocol. So we started like according to your this protocol, you put isotonic.
No, it's not my protocol. It is Hafizi protocol.
Yeah,
Farhad
Farhad
Hafizi,
Hafizi.
who is the one published about hypotonic.
Yeah. So we took this isotonic riboflavin for half an hour.
Yes.
But unfortunately, after half an hour, it became 285.
Yes,
Okay.
because it shrinks.
Then we put for the next 5 minutes. In fact, we put every 20 seconds hypotonic.
Yeah.
Okay, for 5 minutes. Then it came up to 340. Okay, then we put addition 5 minutes.
Yes.
Then it came to 375. But still, it was not sufficient, and we abandoned the procedure.
Yes,
So,
exactly.
do you think that I should have waited for another 5 minutes putting more hypotonic? Or
Yeah, whenever you exceed 10 minutes and you don't find it getting more anymore, it will never get more. So 10 minutes, otherwise if you put 15, 30, it will never go more than this.
Rings.
Sorry?
Rings.
Rings? You mean, yeah, a well over the cornea, and to put, which riboflavin you mean?
That don't
The isotonic.
the thickness better.
To put a ring of what?
Is the ring.
Which ring you mean?
اي حلقه حول اللم حلقات لميه او حتى عدسه لاصقه مسحوبه ضمن التلفان تبع الزراعه القرنيه. بس تعمل سماكه تعمل فيها سماكه لو كان 20 ميكرون او 30 ميكرون. 30. جربنا الطريقه جربنا كثير هي الهيبوتونيك ما نجح. طلع على 30 40 53 ما نجح. طلعنا نعمل عدسه لاصقه نعمل لها كسر بالنص بالتلفان تبع الزراعه القرنيه. نحط ضمن الحوض الهيبوتونيك فبرضه فعلا ما عملوا كانوا جيدين من النتيجه.
Okay, very good idea, really. Now, what I'm going to tell you is another thing, that to use hydroxypropyl methylcellulose. Hydroxypropyl riboflavin, something like this. Hydroxypropyl.
It's not dextran. 0.1%.
No dextran inside. No dextran. And you put it only for 10 minutes. It's very fast penetrating, and it will shrink the cornea very minimum. So if you are planning to do the hypotonic protocol, bring this type, okay, and put it every 2 minutes for 10 minutes only, and then you measure the cornea, and then you go for the hypotonic riboflavin for 5 minutes, and it will be sufficient. Because 10 minutes, so the cornea is not dehydrated, because 30 minutes is too long. And it does not include dextran, so no shrinkage, not that much shrinkage. There will be just a very small loss of thickness, and then you add the hypotonic. It will be the best actually. Pleasure.
What about adding an RCL drops 5% at the end of the procedure?
At the end of the procedure?
Yes, before if you find the thickness of the cornea not enough.
Not enough, okay. An RCL will...
An RCL without, after removing the increase.
No, an RCL will reduce. You mean distilled water? You mean distilled water?
Yes. The drop, no, the hydroxyl drop. With the with the type of the riboflavin, it keeps the nose riboflavin.
Okay, yeah, this is the one.
Yeah, this is the one. You put the hypersense of the RCL at the end of the procedure.
NRCL will increase the cornea, the thickness? I don't think so. NRCL will take off the water from it.
Yes, but if you add this to the
I don't know. But NRCL logically, it does not add, it will take off.
yeah.
You mean distilled water, maybe? Or NRCL half? Not
1.5.
not 0.9%.
0.5.
That's it. So it's half. 0.45. Okay, yeah, it will swell the cornea. It's better than the distilled
The
water.
hypersol drop, the hypersense drop. After putting the cornea.
Yes. So yeah, instead of the hypotonic riboflavin, you may use the half concentration of the NaCl, the normal saline. Yes. It is like distilled water, actually, and swelling the cornea. Yeah. Half, but not the normal
Not the
NaCl.
normal.
Yes.
The one we use it to treat the cornea.
Exactly. Exactly, yes. Okay, done? Thank you very much for your attendance. I enjoyed. Thank you. يعطيك العافية.
انه ناخذ نحن 3 صور اول شيء، يعني قصدك الاول 3 صور لازم يكونوا بنفس الوقت ولا شهر 3 شهور كذا المراقبه؟
لا بنفس الوقت.
بنفس الوقت انا فورا باخذ 3 صور مشان نقارن جوده الصوره يعني بس.
نعم مشان نقارن جودة الصورة. نعم نعتمد على واحدة منهم بس.
هو أنا بالتصنيف آخر بروسيجر بعد ما نشيل الكتيبة نحط هي الهايبر سولفية شيء 5% انقاسة.
بس الانقاسه انه بينقصها
0.5.
ايوه 0.5 تجي اسمها هايبر سولفية أو هايبر سول أو يورو 1 من بعيد فكثير بتزيد.
سؤالي بس عفوا، هاي بس بدي اعرف تبع مين هي؟ تبعي ولا تبعهم؟